Well, thank you very much for the introduction. Today, I'm going to talk to you about the clinical use of anti-SARS-CoV-2 monoclonal antibodies. So antibody formulations have been used to treat infectious diseases for a long time. Historically, we started by using serum therapy, and then we started extracting immune globulins to use IVIG. And then in the 1970s, hybridoma techniques allowed us to identify specific monoclonals. And recent technological advances like B-cell cloning have allowed us to, as a field, generate monoclonal antibodies that are both potent and specific for many different infectious diseases and are broadly used. Now, in COVID-19, antibodies have played a role from the very beginning. Convalescent plasma was deployed early and extensively. More than 500,000 US patients were treated. And in fact, at certain times in the fall of 2020, almost half of all hospitalized patients received convalescent plasma as treatment for COVID-19. Now, early in the pandemic, scientists began identifying monoclonal antibodies from SARS-CoV-2 and CoV-1 infected individuals. And in the recent months, we've had in vitro validation as well as large-scale clinical trials demonstrating efficacy, leading to emergency use authorizations for early treatment and prevention. So now I'm going to talk about some of these antibodies that are currently available through the emergency use authorization for treatment. Now, when we talk about the EUA for treatment, this is for treatment of mild to moderate COVID-19 in adults and children with a recent positive test who are at high risk for progression to severe COVID-19 disease. There are currently 3 antibody formulations that are approved, and we're going to go through the data for each one of these. However, first I want to talk about this concept of individuals who are at high risk for progression. So high risk for severe disease includes a really large group of individuals. It includes all of our elderly individuals, so anyone over the age of 65. It includes people with obesity, defined as a BMI over 25. Now, if we look here on the CDC obesity prevalence map, we can see that obesity is a major issue in the United States. And in fact, more than 40% of Americans qualify for this EUA indication by obesity alone. In addition, pregnant individuals and individuals suffering from any number of chronic illnesses, including chronic kidney disease, diabetes, and immunosuppressive diseases or treatments, as well as cardiovascular disease and hypertension, lung disease, sickle cell disease, neurodevelopmental diseases, or having a dependence on a medically related technology. All of these things qualify you as potentially at high risk for severe disease, so able to receive mAbs for treatment. Now, we have, in the past year or so, been able to do really rigorous clinical trials of several of these antibody formulations through a really unprecedented coalition of industry, academic, and government forces coming together to enable these really fast, rapid trials, both of vaccines, but also of these antibodies. And so if we think of the first of these trials chronologically to publish, it's for the Regeneron antibodies, casirivimab and imdevimab. And these 2 antibodies were the first to show that they were efficacious in preventing hospitalizations and death. So in this phase 3 study of over 1,300 individuals, outpatients with a recent COVID nucleic acid test were given either REGEN-COV or placebo. And what you can see in the figure is that when we look at the primary outcome of related hospitalizations or all-cause deaths, there was a statistically significant reduction, a 71% reduction in the risk of this outcome when treated with the antibodies. So this is a really substantial effect. In addition, the secondary outcomes were also quite positive. So there was a 4-day less amount of time before resolution of symptoms, and there was very rare significant adverse events. In fact, fewer in the treated versus in the placebo arm. The next antibody approved was through the BLAZE-1 study, and this antibody combination of bamlanivimab and etesevimab was studied in conjunction with several doses of bamlanivimab monotherapy. And what you can see when they looked at their primary outcome, which was a reduction in viral load at day 11, if you look at the blue box compared to the pink box, you can see that there's a statistically significant reduction in the viral load at day 11 in this combination therapy. In addition, secondary outcomes of hospitalization, emergency room visits, or death were also decreased in the combination therapy versus placebo. And the final antibody to receive approval is sotrovimab. Now, this is an interesting antibody as it was identified from a SARS-CoV-1 infected individual, and it has broad neutralization capacity. So it neutralizes both SARS-CoV-1 and SARS-CoV-2 variants. And so in a phase 3 trial, which had a planned interim analysis after just 583 participants, they looked at individuals who had fewer than 5 days of symptom and 1 risk factor for severe disease. And they saw that sotrovimab treatment had an 85% relative risk reduction of hospitalization or death. And so this was a substantial effect that also led to this antibody being approved. So these are all available for outpatient therapy. What do we have for treatment of patients hospitalized for their COVID-19 disease? Now, there's just one study that's been published about treatment of hospitalized COVID-19 patients. And this was looking at the Lilly antibody, bamlanivimab, and it showed that basically when individuals who had been hospitalized with a median of 7 days of symptoms, when they compared the placebo versus the antibody treated participants, they found that there were very similar safety and clinical outcomes. And so the DSMB stopped this study early for futility in October of 2020. And then we don't have any evidence supporting the use of these antibodies in patients who are further along in their disease course and hospitalized. So the current EUA allows treatment of individuals hospitalized for a different diagnosis who have an incidental COVID-19 diagnosis, but that's the only context in which these antibodies should be used in hospitalized patients. So the other EUA indication is for post-exposure prophylaxis. And so the FDA EUA is for those individuals at high risk for progressing to severe disease if infected with the right vaccine status and the right exposure. And so the vaccine status means people who are not vaccinated or immunocompromised or elderly and expected not to fully respond. And they need to have an appropriate high-risk exposure, either to an individual that they cohabitate or spend a lot of time with, or because they're in an institutional setting in which a recent case was diagnosed within. So there are 2 antibodies indicated for this, and I'm briefly going to go over the data. So BLAZE-2 was a study looking at bamlanivimab. Basically, this was for post-exposure prophylaxis within a skilled nursing facility in which a recent positive case was identified. So they enrolled individuals and did baseline testing, and then they went back and looked at those baseline tests and analyzed individuals who had had a negative baseline test. And what they found was that in all comers, there was a 57% relative risk reduction for symptomatic COVID-19 disease in treated versus placebos. Now, if you looked at individuals who were either actual residents of the nursing home or high risk for any reason, there was an even greater risk reduction. In addition, the Regeneron antibodies, REGEN-COV, was also tested for prevention, this case in household context. So they looked at 1,500 individuals who had a household contact who had recently tested positive. And what the Regeneron antibodies were shown to do is they were shown to reduce the risk of a symptomatic infection by over 80%. And this was also statistically significant. And so these 2 antibodies are now available for post-exposure prophylaxis. So now let's talk about the real-world implementation of these antibodies and how they're used. So these antibodies are distributed by the government through Health and Human Services to any organization with the capacity to administer them who request them. And so currently there are more than 3,500 distribution sites. And in fact, we have delivered more than 500,000 courses of these antibodies. However, there are obstacles to use of these antibodies. Use requires we have timely identification of eligible patients who have recently been diagnosed and are able to find linkage to a treatment facility. And so in this case, we need both the patient and the provider to understand monoclonals may be beneficial to them and how to access them. Treatment facilities also have a lot of logistical requirements. They need to have providers to perform the triaging and the informed consent. They need pharmacies to mix the antibodies. They need nursing staff to observe the infusions. They need clinical space with appropriate infection control and ventilation requirements. And then they need to be able to provide follow-up for recipients of these antibodies. And given these logistical concerns, the demand for these antibodies often outweighs the supply, which means the use of these antibodies is often triaged. So the NIH panel suggests triaging when necessary, but at my institution, we've found that basically since the beginning of the use, we've had to triage the use of these antibodies on a daily basis. And we follow the guidelines set out by the panel that we should prioritize the treatment over post-exposure prophylaxis. And we prioritize the use for the most vulnerable individuals. So that's unvaccinated individuals, those who are immunocompromised for one reason or another and not expected to have responded to their vaccination, or vaccinated individuals at a very high risk for severe disease. So I want to mention there are real equity issues about these antibodies that shouldn't be overlooked. Use of these antibodies requires both an understanding and a belief that these antibodies could benefit an individual, as well as linkage to a distribution site. So therefore, medically disenfranchised people in our country may really lack the opportunity to benefit from monoclonal antibody therapy. And thus, outreach efforts to broad communities, as well as to providers and trusted medical authorities are really important. The future commercial use of these antibodies will likely include either insurance or co-payment barriers. And there's a big issue with the international use. The vast majority of COVID-19 cases are in places in the world where there's less access to vaccination. And so the ability to deliver these antibodies to those individuals should be a priority for discussion. Now, variants of concern are highly important in how we use these antibodies. As variants shift and their sensitivity to these antibodies shift, the use of the available antibodies will have to change also. So currently an interagency group from the government surveys weekly sequencing data and makes up-to-date determinations about which antibodies can be used. So previously, as an example, the use of bamlanivimab and etesevimab was restricted when there was concern for certain variants that may be resistant to this formulation rising in prevalence in 8 different states. As the concern for lower prevalence of these variants of concern was detected, that we reinstated use of these antibodies. But clearly, moving forward, continued surveillance and thoughtful consideration for resistance and variants of concern is going to be very important. So in summary, these monoclonal antibodies are available via emergency use authorization for the outpatient treatment of early, mild to moderate COVID-19. And currently they are the only available evidence-based outpatient therapy. Randomized controlled trial data strongly support their efficacy with 70 to 85% risk reduction of our most severe outcomes. Infrastructure limits currently reduce our ability to use these antibodies in more than the most vulnerable individuals. And so we triage their use for treatment of unvaccinated or immunocompromised patients largely, which raises issues for equity and education and logistical concerns that need to be continually addressed. Finally, monoclonal antibodies have been shown to be efficacious for post-exposure prophylaxis. However, currently their use is limited, again, mostly due to these logistical concerns. Thank you very much.